Survivorship is a term that reflects much of the activity of a general practitioner. You know, looking after the patient as a whole, the biopsychosocial model of care, and the fact that survivorship means more than treatment of the cancer. It's that ongoing journey with the cancer diagnosis, looking after the patient, looking after the carers as well. And for us as general practitioners, working closely with our hospital partners and also allied health practitioners.
I think survivorship care really lends itself to a shared care model between specialists and GPs. And I think that as time goes by, we will see this model of care being implemented more and more.
So once the treatment is over, then patients may come and ask you about the things that they might be doing to improve their recovery and obviously to improve their chances of long-term survival. And this is where an opportunity to look more broadly at their lifestyle is really important. So looking at important lifestyle factors, diet as well, maintaining a healthy weight, stopping smoking if you do smoke, and reducing alcohol. These are all core aspects of a healthy lifestyle that, again, is a key bit of what general practice can offer to support better survivorship care.
I definitely saw that my primary point of contact is my GP in terms of knowing my holistic self, and because it's not just the cancer, the GP's and looks after all aspects of my health. So it was good to have her involved.
I think increasingly we recognise that there are many people who will be cured of their cancer, but they have other medical conditions that need addressing because they're much more likely to impact on their long-term both quality of life but also on their survival. So we have a role in identifying those issues, highlighting them together with their general practitioners preferably. And in many cases, it's now a case of being able to discharge from care at hospital level back to the general practitioner, but giving the general practitioner a very clear way of referring patients back if they're concerned that they might have an issue which is related to their cancer.
An example I give is a patient that I look after in my area. He had a diagnosis of CML on the background of multiple sclerosis. It was up to our practice, our nurses, to engage with the haematologists, the allied health providers, and yes, he had great treatment, he had oral chemotherapy, but there were some side effects, and it was decided by the specialist that the general practitioner should look after the side effects of treatment, and that's where good communication equaled good care.
So much of what can be done better in this area is communication. And it's important at the end of treatment or even at different stages of the treatment that the information we provide to GPs is thorough and clear. And there are opportunities to reference it to other documents which mightn't be specific to that particular patient but can also be helpful. What I'm referring to here are the optimal care pathways that have been developed through the Health Department and the Cancer Council of Victoria, and they are often a very good guide for what to expect for a patient right through the cancer journey.
Then GPs are used to communicating with specialists when they're referring a patient in. What they're not so familiar with is the idea that they should be sharing results of follow-up tests with the specialist. So again, it's about really trying to identify that and improving two-way communication so that everybody is aware of what's going on, which is just a key aspect of good shared care.
I think it's very important for the oncologist to communicate well with a person's GP so that each person in the care team knows what their roles and responsibilities are. And when I talk about the care team, I actually include the patient within that. One way that we can provide that information to GPs is through a document called a survivorship care plan. And this is a document that's generated by the specialist that includes all the details of the patient's diagnosis and treatment, which may not be known by the GP, and also what their current health issues are and their potential health issues are. Included in this document will be a clear outline of what needs to be done for the patient and whose role it is to do that. Importantly, there'll also be clear information there regarding how the GP can communicate with the specialist should there need to discuss the ongoing management of that person.
What I would encourage GPs to do is to feel free to engage more with the specialists. We all are busy in our different roles, and there are some things that need to be attended to more quickly than others. But I think it's fair to say that because we now work in cancer teams, there is nearly always a member of the team that is available to discuss a particular issue. And part of it is letting us know, the GPs, that we're comfortable with that. And the other part of it is that the GP should be very comfortable to contact us as specialists too.
Ideally for both specialists and general practitioners is agreeing when the hospital now takes a back seat and general practice takes on the ongoing care needs. Long term, it doesn't become so much of a cancer surveillance issue, but the fact that many of our cancer patients do have cardiovascular risk factors, mental health issues, and they're things that prominently GPs should be looking out for, and in turn preventing, other conditions and making sure that they get the flu shot, the pneumonia shot. That might be something that is important in their long-term care.
I think all GPs recognise this is as a potentially growing role, and that should become an educational need. So they may recognise that they need to attend some additional training or courses to upskill themselves in survivorship care. And there are certainly a range of opportunities within Victoria and through the Survivorship Centre to help with that upskilling.
If we look at the RACGP, what GP should be doing, it's continuing coordinated comprehensive care. And we're not confident in looking after cancer patients, whether the cancer itself or related issues or side effects of treatment, then I think we're not doing our job. We have a role and we need to work with our colleagues for patient care.